Now, there are a number of compensatory mechanisms that the body sets off when it sees heart failure. Remember, I mentioned them just a few moments ago. What are the compensatory mechanisms? Well, let's think, why would the body compensate for decreased cardiac output, for decreased pumping of the blood? The reason the body compensates is because it interprets heart failure as if there had been a hemorrhage, blood loss, or dehydration. In other words, the reduced pumping ability the body interprets as, oh, there's a lack of blood from a hemorrhage, or there's a lack of fluid in the circulation because of dehydration. And it sets off a whole bunch of compensatory mechanisms aimed at holding on to fluid, water, and salt. Unfortunately, this is exactly the opposite of symptoms. There's a lot of cut off when it sees heart failure. Now,
Stop ako kahapon sa definition. So, nakapatopin na. Excuse me.
Now, there are a number of compensatory mechanisms that the body sets off when it sees heart failure. Remember, I mentioned them just a few moments ago. What are the compensatory mechanisms? Now, there are them just a few moments ago. What are the compensatory mechanisms? Well, let's think. Why would the body compensate for decreased cardiac output, for decreased pumping of the blood? The reason the body compensates is because it interprets heart failure as if there had been a hemorrhage, a blood loss, or dehydration. In other words, the reduced pumping ability, the body interprets as, oh, there's a lack of blood from a hemorrhage, or there's a lack of fluid in the circulation because of dehydration. And it sets off a whole bunch of compensatory mechanisms aimed at holding on to fluid, water, and salt. Unfortunately, this is exactly the opposite of what we would want, because in holding on to fluid, you actually create the setting where patients put some of that fluid into the tissues, both in the legs as edema or in the lung as pulmonary edema. So the activation of the neurohumeral system, that is central nervous system,
output in the face of decreased myocardial contractile function, a number of compensatory mechanisms, cardiac muscle hypertrophy, so lumalaki yung cardiac muscle, dilatation or both, tachycardia, neurohumeral system, sympathetic nervous system, or
activity to correct the heart failure situation actually makes the situation worse. These systems work great if there's dehydration, you're caught in the desert without water. They work great if there's a hemorrhage, you've been cut somewhere, or you're bleeding from an ulcer in your stomach. But they work, unfortunately, in a negative manner in the patient with heart failure. Let's just talk for a moment about why these compensatory mechanisms work. They work because of something I mentioned before, Starling's law, the so-called rubber band law of the heart. The more you fill it, the more it contracts. So what the compensatory mechanisms are trying to do is to increase the filling of the heart so it will squeeze more. As I've said, unfortunately, that leads to elevated pressures that back up in the system and result in edema. But the rubber band law of the heart says that the force of contraction is related to how much you stretch the heart muscle cells, and this increases contractility. So you see why the body is trying to increase the pumping ability of the heart, and this works fine if it's a hemorrhage or dehydration, but it doesn't work well when the patient has heart failure. So remember, stroke volume is the number of cubic centimeters that the heart puts out with each time it squeezes, times heart rate, that's cardiac output. So when we have a reduction in stroke volume because the heart has been injured, sometimes you'll even see the heart rate go up because the central nervous system says, oh, cardiac output is falling. We have to increase the heart rate. We have to increase our ability to hold on to salt and water and increase the blood volume and use the Starling law to increase the contractility of the heart. Again, unfortunately, it's not the right setting for that, and this leads to overfilling of the circulation, increased pressures in the circulation, and increased fluid getting out into the lungs and into the tissues. So the central nervous system says, oh, cardiac output is falling, we have to increase the heart rate. We have to increase our ability to hold on to salt and water and increase the blood volume and use the Starling law to increase the contractility of the heart. Again, unfortunately, it's not the right setting for that, and this leads to overfilling of the circulation, increased pressures in the circulation, and increased fluid getting out into the lungs and into the tissues. So the central factor in heart failure, of course, is depression of the heart muscle, at least for systolic heart failure. But also in diastolic heart failure, the heart is supposed to actively relax, and there's also depression of that. But the commonest form of heart failure, as you've seen in the previous slide, was systolic, and it is usually because there's been some injury to the heart muscle, most commonly from ischemic or coronary artery disease with heart attacks. And again, we've talked about the compensatory mechanisms. Here are the compensatory mechanisms listed. First of all, they're initiated by the central nervous system. One of them is a signal that's sent to the kidneys and that the kidney actually does on its own. The kidney is the regulator of the blood pressure in the body. It sees a drop in blood pressure, a drop in cardiac output, and it releases compounds in something called the renin-angiotensin system, which holds on to salt and water. It's hormones that actively tell the kidney, hey, don't pee out sodium and water. Hold on to it because the circulatory system needs some volume. There are also hormones that are released from the pituitary, so-called antidiuretic hormone, which tells the kidney, hey, hold on to water. Don't let the water go out in the urine. In addition, you also will have activation of the sympathetic nervous system, which is part of the flight or fight system. This sends adrenaline to the heart muscle to try and get it to contract more vigorously, and it also clamps down a little bit on the periphery in an attempt to shrink the volume that the heart has to pump into. All of these compensatory mechanisms, you can see, they work great if we're talking about dehydration or hemorrhage, but they work in the wrong direction when the patient already has a depressed left ventricle. The other thing that happens is that the heart muscle remodels. It reconstructs itself, if you will. You can see in this diagram on the left, there's one form of remodeling, left ventricular hypertrophy, where the ventricle markedly thickens, for example, with aortic stenosis, as we talked about with the patient in the last lecture. On the other side is the sort of thing you see in a cardiomyopathy. The heart dilates, thickens a little bit, but predominantly what it does is it dilates. And you've all heard someone say, oh, so-and-so's in trouble. They have a, quote, big heart. That's because the heart's dilated. That's often the final stage of heart failure, when the heart has exhausted all of its other compensatory mechanisms to get the cardiac output up. Then you start to see this dilatation.
Should the following chemical compounds increases the heart rate? I'm not so sure.
Of the left ventricle.
Next are in types of heart failure. Wait lang. So ano nga bang naalala
Now,
ko? Ano ba naalala ko doon? Patopy. Alam ko lang it's either dilated yung ventricles or nagkakaroon ng cardiomegaly o pwede rin na nagka-hypertrophy due to, in cases of aortic stenosis. Then, so yun, nagkaka-problem nga daw yung compensatory mechanisms supposedly ng decreased cardiac output, which is computed by stroke volume times Ano ba? Next. Stroke volume pala. Stroke volume times heart rate equals cardiac output in liters per minute. Yun. So, pag bumaba yun, may compensatory mechanisms. However, hindi siya maganda sa cases ng heart failure na sa halip na makatulong, nakakalala pa. For example, yung pag-act ng raas. So, sa halip na basta increased yung retention ng water na ibig sabihin pag maraki yung fluid sa vascular system mo, napupush lalo dun sa mga spaces sa tissues which causes edema, and specifically mga pulmonary edema. Ano pa? Ayun. Mas common ata yung yung systolic heart failure. Kasi usually daw mas common na na-affect yung ventricles. Or tama ba? Sige na, next.
Again, we talked about the different kinds of heart failure, systolic and diastolic, but sometimes there are definitions based upon which ventricle is in the most trouble.
Wait lang po.
Most common is left-sided heart failure. That's because the left ventricle has been injured. But in some conditions, such as severe lung disease with high pressures in the lung, you may just see isolated right-sided heart failure. So let's think about this for a moment. With left-sided heart failure, the backup is going to be into the lungs. Patients get fluid in the lungs and they're short of breath. So the edema is in the lungs with left-sided heart failure. With right...
Wait. Most common form of heart failure, left side. Fluid may build up in the lungs, causing shortness of breath. Okay. Pulmonary edema. Right-sided heart failure often occurs with left-sided heart failure. Fluid builds up in the abdomen. Kasi right side. Kaka-problem doon. Pag nag-failure yung left side na supposedly po systemic na galing sa okay. Right. So, syempre pag yung right side ng heart natin, then yung after nun, or before yon galing sa iba't ibang system. So, doon nagkakaroon ng problem. May build up sa abdomen, legs, and feet, which causes peripheral edema.
Sided heart failure.
Shout out kay Shane Selajes. Nanonood siya ngayon. Wash out loads.
The backup is into the veins, so you often see patients with fluid in the abdomen, fluid in the legs, so-called peripheral edema. And the left ventricle may be working just fine, but it's not getting any blood from the right ventricle because the right ventricle is failing. And of course, it's obvious what the left ventricle puts out depends on what the right ventricle puts out. They have to balance out. If they don't balance out, all the blood is going to end up on one side of the circulation or the other. And then we've talked about before systolic heart failure, failure of contraction, diastolic heart failure, failure of relaxation. Patients with chronic heart failure can be divided into two broad categories based on whether their ejection fraction is normal or reduced. These two categories are heart failure with preserved ejection fraction, called HFpEF, and heart failure with reduced ejection fraction, called HFrEF. Sometimes the third category is implied and used, and that's heart failure with mildly reduced ejection fraction of 41 to 49%, because normal, of course, is above 50%. For the most part, it's important to know the differences between the two distinct mild and heart failure with reduced ejection fraction is normal or reduced. These two categories are heart failure with preserved ejection fraction, called HFpEF, and heart failure with reduced ejection fraction, called HFrEF. Sometimes the third category is implied and used, and that's heart failure with mildly reduced ejection fraction of 41 to 49%, because normal, of course, is above 50%. For the most part, it's important to know the differences between the two distinct types of heart failure. About half of the patients with heart failure have HFpEF, and about half have HFrEF. This distinction has prognostic value, and it also helps guide therapy for the patients with heart failure, since therapy is different for HFpEF and HFrEF. HFpEF is defined as a left ventricular ejection fraction of 50% or more in a patient with signs and symptoms of clinical heart failure. Although most patients with HFpEF have diastolic dysfunction with elevated filling pressures, asymptomatic diastolic dysfunction can be seen with normal aging in individuals who do not have clinical symptoms. So, although people with diastolic dysfunction have a risk factor for HFpEF, these two terms are not synonymous. HFpEF must be distinguished from other causes of heart failure in patients with an ejection fraction greater than 50%. And these include patients with valvular heart disease, pericardial disease, cardiac amyloidosis, and
Wait lang, habulin ko. Most patients with HFpEF, normal left ventricular volume, increased filling pressure. Not all patients with diastolic dysfunction have HFpEF. Asymptomatic diastolic dysfunction is seen in patients with stage B heart failure at risk for HFpEF. These terms are not synonymous. HFpEF must be distinguished from other causes of heart failure with an ejection fraction more than 50%. Valvular heart disease, pericardial disease, cardiac amyloidosis, high output heart failure such as with severe anemia and hyperthyroidism.
High output heart failure, such as that seen with severe anemia or hyperthyroidism. Heart failure with reduced ejection fraction, or HFrEF, is defined as a left ventricular ejection fraction less than 50%, although an ejection fraction in the 40s is sometimes called mildly reduced ejection fraction. Patients with HFrEF have difficulty with the pumping function of the left ventricle, the heart, and by definition, a reduced ejection fraction in the left ventricle known as impaired systolic function. Decreased ejection fraction leads to inadequate tissue perfusion and, of course, influences the prognosis of the patient. As you might expect, the lower the ejection fraction, often the worse the patient does and the more symptoms they have. Cardiac remodeling is a response to hemodynamic load as well as neurohormonal activation.
Pathological remodeling can be seen with pressure overload due to hypertension or aortic stenosis. It can also be seen with volume overload with valve.
No, quiz. Sakto, lumulutang utak ko. You should have always most likely caused peripheral, right?
Regurgitation, or with cardiac injury, for example, myocardial infarction. The management of HFpEF is quite different from the management of HFpEF, and it's important to know the differences.
Here's just a little diagram to remind you how the whole body is a coordinated system. You see the brain is connected to the heart, the brain is connected to the kidneys, they're all connected to the peripheral blood vessels, and as we've talked about, when there's heart failure or when there's dehydration or when there's hemorrhage, all of these factors become activated in an attempt to A, restore the blood volume, and B, restore the pumping ability of the heart. And here they are, all listed again, just as we've talked about before. The central nervous system is critical. The sympathetic nervous system is activated. The kidney, through the renin-angiotensin system, is activated. And the ventricle gets increased volume and therefore uses the Starling mechanism. All of these things work together. They work great if the patient's blood volume is down because of dehydration and hemorrhage. They work against you when the problem is that the heart is not pumping enough. And again, here you see a diagram that just shows you how all of these interact, how the decreased cardiac output can lead to lung congestion, and how increased peripheral pressure can lead to peripheral edema. The neurohormonal activations through the kidney that go on, all of these things are working in a complete circus motion, like a horse riding around the track in a circus. Around and around, they keep reinforcing each other, and unfortunately, in heart failure, lead to marked retention of water and salt that leads to the various symptoms that the heart failure patient has. In the American Heart Association guidelines, talk about various levels of heart failure. Level A is somebody who's really predisposed to heart failure but has not developed it yet. So that's somebody with high blood pressure, diabetes, hypercholesterolemia, hyperlipidemia, as we've talked about, that leads to atherosclerosis. Heart failure hasn't developed yet, but the substrate, if you will, is ready to go on and cause a heart condition that will lead to heart failure. Grade B is when you're starting to have some very early signs of heart. Drugs for chemotherapy for breast cancer also damages the heart, and some other drugs can do the same thing. And of course, arrhythmias with long-standing fast heart rate that's uncontrolled can also lead to cardiac fatigue. These things are much rarer. Remember, ischemic heart disease is #1 public enemy. And here you just see all of the symptoms that patients will have with heart failure. They will be dyspneic, that is, they'll be short of breath. You will find maybe their lips are blue because they're not pumping enough oxygenated blood around. There may be heart murmurs, as we had in the patient in the last lecture with aortic stenosis. Sometimes on physical exam, you will hear a loud extra heart sound that says the ventricle's really hurting. The patient's breathing fast. You may hear actually sounds from fluid in the lungs and so forth. There's a whole variety of physical findings that the doctor finds that confirms the diagnosis of heart failure. Remember from the last lecture, the most important thing are the symptoms. They give you the clue. 90% of the answer of the diagnosis is in the history. You then move to the physical exam. Oh, yes, I'm hearing things, I'm seeing things that suggest that the reason the patient is tired, the reason the patient is short of breath, the reason the patient has swelling in their legs is because of heart failure. Right ventricular heart failure alone can cause a different set of symptoms and signs. Of course, the edema, the extra fluid, is in the legs. And you will remember that you may have problems in the abdomen because the increased venous pressure backing up is not only in the legs, but it's also in the abdomen. The liver swells. So there's also swelling in fluid in the abdomen. Patients may find their waist size gaining. They become very, very tired, and often you can even feel on physical exam this bulging abdomen that's full of fluid. Remember again, right heart failure, much less common than left heart failure. Commonest cause of left heart failure, ischemic heart disease, that is, previous heart attacks. So here's a few diagrams that just show you what the cardiologist sees when they see a patient, usually with very clear and significant heart failure. And you can see their pupils may be dilated from the adrenaline that's circulating. The skin may be gray or pale or even blue, cyanotic. And a whole bunch of things. They may be short of breath, breathing fast. They may be uncomfortable lying back and feel more comfortable breathing sitting up. There may actually be sounds in the lungs from fluid in the lungs, crackles or so-called rowels. They may have a cough from the excess fluid that's in their system. There is often increased pressure in the veins, and you can actually see that in the neck. I'm going to show you a picture of that. And the blood pressure may be decreased because the cardiac output is down. And also the patient may even have some discomfort in the abdomen, swelling and nausea and so forth. And of course, you may see bulging of the abdomen, as I mentioned, and edema that is swelling in the legs. All of these are not seen necessarily in one patient, but in individuals you may see a number of these findings. And of course, patients' anxiety level is increased, of course, because they're short of breath. One of the worst things that can happen to you is to be suffocated. It activates anxiety in a huge way. And again, you may see the fact that the patient has decreased oxygen saturation. Often we can test that with a little finger thing or an ear thing to see that the oxygen level in the blood is going down. The patients in advanced heart failure may be confused, particularly in elderly patients. There may be, as I'm going to show you a picture in a moment, the jugular vein is distended because of high filling pressures in the right atrium transmitted back to the jugular vein. There can, if the patient's had a heart attack, there may be chest discomfort in association with this. Of course, the patient is markedly fatigued, and you may hear the heart sounds that I mentioned before, this extra heart sound. The heart may be increased in rate. And again, you may feel swelling of the liver or the spleen from the venous congestion that goes back there. And of course, there's decreased cardiac output if you measure that, often with an echo, and the pulse may be therefore weak. The patient is often cool. The skin may be sweaty. So here's a picture. This is a lovely picture of a distended jugular vein. You can see it rising up from just above the clavicle, the bone that's right here on the front of the chest, and you can see rising up almost to the level of the jaw. So this is a patient with quite advanced heart failure. In this case, it's a finding of right ventricular failure, but the commonest cause of right ventricular failure is often left ventricular failure that increases pressure in the lungs, increases the work of the right ventricle, which eventually fails. So this could be a patient with left ventricular and right ventricular failure, or it could be somebody with isolated right ventricular failure. And here we see an example of peripheral edema. You can see you push into the soft tissue of the leg, and you'll notice that the impression stays when you take your finger away. So this is a patient with advanced peripheral edema. It also looks to me like the skin doesn't have its normal tone, its normal color. It looks gray and mottled, and often this is because of decreased cardiac.
Which of the following is least likely to be seen in patients with heart failure? Looks nga. Distension na wala. Okay, wait, see. No. Okay. Should I follow this right-sided. Pag-right. Which of the following is least likely to be seen? Decrease dyspnea, increase appetite, cyanosis, heart rate. Next. Which of the following is the most common cause of heart failure? Ischemic. Yung pinaulit-ulit na yan eh. Bakit hindi ako confident?
Cardiac output.
Doon nag-appear yung quiz. Hindi pa nga tapos magsalita eh. Testing on patients. Tingnan natin yung so last na daw to. Cardiac tumors. Yung last na pang heart failure.
So, of course, we're going to do some tests to confirm our clinical impression. We've had the history. Oh, this suggests heart failure. The patient's short of breath. They have peripheral edema. Oh, we listen to the heart and we hear an extra sound, the S3 gallop. Okay, we're now pretty sure the patient has heart failure. Then we do a chest x-ray. You can see the two examples here. The one on the one side is normal and the one on the other side shows an enlarged heart. Sometimes we will even see evidence of fluid in the lungs. Pretty obvious on this chest x-ray. This is called pulmonary edema. The left ventricle has failed significantly, and what we see is fluid throughout the lungs. And of course, this patient is very short of breath. They might be breathing at 30 or 40 times a minute. Normal is about 12, 13, 14 times a minute. And you may actually hear gurgling from this fluid that's collecting in the small alveolar sacs in the lung and being transmitted into the bigger bronchial tubes. This can drop the oxygen saturation in the blood, can lead to fatal arrhythmias, and people can die from this. And this is a medical emergency that requires urgent therapy. And here is a chest x-ray showing a variety of findings of a little less serious heart failure. One can see edema in the lymphatics, so-called curly lines. One can see fluid collecting in the pleura. You can see in the little angle there where the heart meets the chest that there's a little sort of rounded area. That's actually fluid in the pleural space, the space that surrounds the lungs. There's a variety of other findings that the radiologist will often call you up and say, your patient has heart failure. We often do an echocardiogram to see how bad of the heart failure is. For example, is it left ventricular? Is it right ventricular? Is it very advanced? Is the ejection fraction, that is the percentage of blood squeezed out by the heart, very low? Or is it only modestly reduced? This is an echocardiogram from a patient with a very advanced heart failure. The left ventricle is markedly dilated. We don't see the film with it, but I'm sure if we saw the film, instead of the ventricle squeezing normally like this, it's doing this. Hardly squeezing at all. And you can see also in this echo, the left ventricle is enlarged. So this is a patient with long-standing heart failure. So let's talk a little bit about treatment. Clearly, treatment goals are to reduce the edema, to reduce the excess fluid volume, and to make the patient much more comfortable and able to have full activity. You'd also like to increase the pumping ability of the heart. Sometimes, if it's, for example, in the patient we talked about in the last lecture, somebody with aortic stenosis, Taking away the stenotic valve and putting in a good valve allows the ventricle to recover. In other settings, if it's due to severe ischemia, lack of blood flow in the heart, coronary bypass or angioplasty may improve the blood flow in the heart and may, not always, but may improve the function of the ventricle and again lead to resolution of symptoms. And there's a variety of drugs that help increase the removal of fluid from the body. For example, diuretics that increase renal excretion of water and salt will reduce the excess volume of salt and water in the body and often lead to marked improvement in the symptoms. Patients with heart failure, particularly new heart failure, require hospitalization. They require a number of tests to determine why they're in heart failure, and they also require a number of drugs that are used to improve, if possible, the function of the heart and to decrease the work of the heart and to increase fluid and salt excretion. And what you do, this step diagram is a complicated one. I'm not anticipating that anybody needs to learn this right away, but it shows you as the heart failure increases, the aggressiveness of our therapy increases. So in the beginning, we use ACE inhibitors. That is, they vasodilate the arterioles, they decrease the blood pressure a bit, and they decrease the work of the heart. In a sense, what we're trying to do is rest the heart, make the heart's job, the left ventricle's job, a little easier. But as you go along, there's a variety of other interventions that are used, both improving blood flow, for example, with angioplasty. We also use drugs that rest the heart a little bit by decreasing the heart rate, beta blockers. And then eventually you may even progress to devices that increase the pumping ability of the heart while you're getting ready to do something more aggressive, for example, change a heart valve, or even in the most severe stages, do a heart transplant, give the patient a new heart. It's important that patients have lifestyle changes, particularly with the milder forms of heart failure, because what we're trying to do is prevent heart failure from progressing. So what are those lifestyle changes? Clearly, somebody who's obese, you've got a lot of extra weight around. If you have a big belly that has 40 or 50 pounds of extra weight, it's like you're carrying a 40 or 50 pound knapsack on your back and you're asking the heart to do that extra work. You can imagine that's a bad idea. So dieting and reduction of obesity is important. Number two, cutting back on salt, because the more salt you take in, the compensatory mechanisms of the body hold on to that salt and, of course, increase blood volume. So restriction of salt. It turns out that regular, particularly in the beginning, supervised exercise or physical activity actually improve the whole cardiovascular system and enable patients to do more work with the same cardiac output that they had before. And of course, stopping things like cigarette smoking, which are damaging to the blood vessels and which can cause acceleration of atherosclerosis, just as we talked about in patients with a heart attack or coronary artery disease. There's a whole variety of lifestyle changes, and often these are integrated between the cardiologist and a good cardiac rehabilitation program.
Medication management is tailored to the type of heart failure that a patient has, whether they have heart failure with preserved ejection fraction, as we already heard, called HFpEF, or whether the heart failure patient has a reduced ejection fraction, so-called HFrEF. And of course, medication management is tailored to the patient's symptoms and signs. If a patient has volume overload with dyspnea or peripheral edema, of course, they need diuresis, usually with a loop diuretic to remove excess fluid. For patients with a compelling indication for a specific type of antihypertensive medication, for example, if a patient has diabetes or chronic kidney disease, then an ACE inhibitor or an angiotensin receptor blocker should be used before starting HFpEF specific therapies, such as mineralocorticoid blockers or SGLT2 inhibitors. Of course, you have to look carefully at the patient's renal function. If it is quite impaired, then ACE inhibitors or ARBs are contraindicated because they might make the renal failure worse. For patients without diabetes, then, heart failure-specific medications are indicated. The next step is to add a sodium glucose co-transporter 2 inhibitor, SGLT2 inhibitor. I like to call them FLOSMs because that's part of their generic name. Or, of course, and or a mineralocorticoid receptor antagonist. SGL2 inhibitors are medications like empagliflozin or dapagliflozin. You notice the term flozin in the middle of those terms. A mineralocorticoid receptor antagonist, or MRA as it's often known, such as spironolactone or eplerenone, can be added. If the patient has a systolic blood pressure below 100 or symptoms of hypotension such as dizziness or other orthostatic symptoms, then other antihypertensive drugs should be decreased or discontinued, otherwise you're liable to have severe symptomatic hypotension. The primary therapies for heart failure with reduced ejection fraction are ACE inhibitors, angiotensin receptor blockers called ARBs, or the combination medication of an angiotensin receptor blocker and a neprilysin inhibitor put together are called ANRIs, and the neprilysin inhibitor is known as sacubitril, and it's a blocker of the breakdown and enzymes for atrial peptides. Thus, the ANRI drug is a double vasodilator. And again, you have to be careful about the blood pressure. Beta blockers should be added if there are no contraindications, and the specific three that have been demonstrated to benefit patients with heart failure are carvedilol, bisoprolol, and extended-release metoprolol succinate. If patients have contraindications to any of the renin-angiotensin system's antagonists, an alternative is hydralazine plus a long-acting nitrate. A typical contraindication to the renin-angiotensin system antagonist is advanced renal failure, because these drugs could increase the level of renal insufficiency. In patients who still have symptomatic heart failure, secondary therapies may be added in addition to the initial medications. And there's considerable current debate about the order that we give these drugs, which one should be first, which one second, and that is the subject of current ongoing heart failure research. These include the additional drugs that could be used. For example, mineralocorticoid receptor blockers, as we've already said, spironolactone and eplerenone, or the SGL2 inhibitors, again, that were just mentioned. In certain symptomatic patients, we may need to consider cardiac resynchronization therapy done with a special form of pacemaker that also stimulates the left ventricle as well as the right ventricle, or transcatheter mitral valve repair, for example, clipping a loose mitral leaflet that's allowing for severe mitral regurgitation. You clip that to another leaflet, and thereby you decrease the amount of mitral regurg. Further secondary therapies, newer medications, include Versequat or Avabradine. So Versequat is indicated for patients with New York Heart Association class 2 to 4 heart failure with an ejection fraction less than 45%, who were either hospitalized in the last 6 months or require outpatient IV diuretics. Avabradine is a very interesting new class of medication called hyperpolarization activated cyclic nucleotide gated channel blockers. What they do is they actually decrease the rate at which the sodium channel leaks in sinus node cells, and that results in a slowing of the heart rate. It's indicated for patients with an ejection fraction of 35% or less who are in sinus rhythm with a resting heart rate that's at least 70 beats per minute, and despite the beta blockers, or in beta blockers are either contraindicated or cause problems, then you can substitute the slowing drug using Avabradine. Digoxin can be added to patients with end-stage heart failure who are not doing well despite optimal other pharmacologic therapies, as well as cardiac resynchronization therapy. Lastly, mechanical circulatory support devices as left ventricular bypass pumps and intra-aortic balloons and even cardiac transplantation, may be considered in some highly selected patients with refractory heart failure.
And again, there's patient counseling. We already talked about the lifestyle. Alcohol is a depressant on the heart, so we want patients drinking as little as possible. Smoking has to stop. We want weight control. We want regular exercise. All of the lifestyle things, again, repeated, to work with the medicines that we're giving or to work with the interventions, for example, opening up a coronary artery or replacing a heart valve. And further patient counseling, of course, involves the medications. Are the patients taking the medications, and are they taking them regularly and as appropriately prescribed? This is a huge problem. In the United States, many patients fail to take their medications. If there are surgical or catheter interventions, what these contain and what they can do and what the potential complications are. One wants to reduce stress in the patient's life. One wants the patient to keep track of symptoms. Are they getting better? Are they getting worse? Is their weight gaining all of a sudden because of a marked increase in fluid retention? And of course, we would like patients to not overindulge in fluid intake and certainly come for follow-up visits with the doctor or the nurse clinician in order for us to monitor how things are going with therapy and if we have to make further adjustments in therapy. So, in conclusion, heart failure is a growth industry, particularly in older individuals. It's caused by many diseases, but in particular by atherosclerotic heart disease that causes damage to the left ventricle. Again, left ventricular systolic heart failure is the commonest. The left ventricle doesn't squeeze as well, and the commonest cause of that, ischemic heart disease. Prevention, of course, is better than cure. I don't have to tell you that. And how do we prevent that? By controlling atherosclerotic risk factors before they put the patient in the heart failure situation. Of course, there's a whole variety of diagnostic tests that we use when the patient presents with heart failure. But remember, the clue is in the patient's symptoms with confirmation by the exam, and then we do some sophisticated tests to see what's the cause of the heart failure and how severe is the ventricular damage. And then we introduce a whole variety of therapies, both drugs and even some of the newer device therapies. For example, we can open up blood vessels, and even in extreme cases, we can take over with little pumps for the heart while we're trying to get it to respond and come back to normal. And of course, then we're going to have to do lifestyle changes. There's a new pacing protocol with a special pacemaker that can, in some selected patients, can improve the pumping of the heart. All of these are fairly extreme things done right at the end. And again, we talked about the fact that there's a lot of technology here, but the best deal is to stop the heart failure before it starts with reduction in risk factors, or identifying it early and getting all of those things, including the lifestyle changes, implemented before the patient progresses to a point that they need things like biventricular pacing and heart-lung machines and so forth. Thank you for listening to this lecture. I look forward to seeing you with the next one.